Discrepancy in healthcare among African Americans. Brass tacks. In 1941, African American author Richard Wright had said, "We black folk, our history, and our present being are a mirror of all the manifold experiences of America. What we want, what we represent, what we endure is what America is. The differences between black folk and white folk are not blood or color, and the ties that bind us are deeper than those that separate us. The common road of hope, which we all have traveled, has brought us into a stronger kinship than any words, laws, or legal claims." Today, Black Americans make significant contributions to every segment of American society: business, arts and entertainment, science, literature, medicine, politics, and law. African Americans endure, achieve, and lead, even as issues of discrimination remain in nearly every sector, including the most basic of fundamental human rights, the freedom to health care. So what does one mean when one says that America is truly the land of the free? What is the ultimate American dream? To some, it is about contributing selfless service to the nation, while for some, it is simply about raising a family in an equal, race-free, safe, and fair society. While no one has the exact same idea of the American dream, most agree that it is about having freedom and the security of equality in opportunities, rights, and most importantly, health care. The phrase "land of the free" has attracted controversy over the decades, but ultimately, most will agree that it is about securing and safeguarding the vision of the forefathers, a land where health care is available equally for one and all, regardless of one's color, creed, or racial ethnicity. But has that truly happened? Especially in the case of healthcare. Hi everyone, you're listening to Discrepancy in Healthcare in America. 19 years ago, a report published by the Institute of Medicine titled "Unequal Treatment" shocked everyone with a wide body of research that demonstrated that racial and ethnic minorities in the United States are less likely to receive healthcare than whites, and often receive lower quality preventative treatment. The report also most startlingly brought forth the fact that despite factors like income, neighborhood, complex illnesses with multiple symptoms, and health insurance type, that are keys to understanding racial disparities, the health of Black Americans was still worse than that of white Americans. The research also resulted in the Institute of Medicine suggesting a list of aims for the U.S. healthcare system, but efforts to ensure equality amongst all Americans to avail healthcare of similar quality have still been given less attention than expected, including factors like quality and reduced costs. A more recent paper titled "Equity, the Forgotten Aim" noted how little progress has been made. For example, the state of California, which is perhaps the most culturally diverse of any state in the U.S., with also the fifth largest Black population in the country, stands to benefit from health equity. But research has pointed out otherwise. Racial and structural barriers prevent Black Californians from achieving the health they actively seek. To set the context better in numbers, the CHCF, or the California Healthcare Foundation, conducted a survey and summarized its interviews with 100 Black Californians and 18 focus groups, as well as 3,325 adult Black Californians. According to the research, the said community is highly intentional in availing of physical and mental health care. About 79% reported focusing on their mental health. 77% expressed concerns about getting appropriate screenings or preventative care, while 71% were yet to track health indicators, such as blood pressure and cholesterol. Advocates, on the other hand, expressed the need on the part of healthcare professionals to acknowledge and factor in race and racism into healthcare, while also pointing towards less directed efforts that may lead to worse outcomes for Blacks, Hispanics, or other patients of color and ethnicity, thus not leading to gains across these affected groups, and only magnified racial health disparities. Interestingly, reports also indicate that most Black Californians are insured, with most having visited with a healthcare provider at least once in the last year. 9 in 10 Black Californians, 90%, claim to have health insurance coverage, while 83% have access to a regular provider. Over 9 in 10, that is about 92% Black Californians, have seen a doctor or healthcare provider in the last year. But contrary to these numbers, some voices have also come out raising serious concerns about the failures of the healthcare system. One focus group participant who had private insurance categorically expressed that she felt like Black voices aren't as loud, that she had not been taken as seriously, was not listened to, and it ended up being a very serious, actually life-threatening problem for her. She had visited her doctor complaining of shortness of breath, and the doctor instead told her that she was out of shape and that she just needed to lose weight and exercise more. This ended up with her getting severely anemic and having to undergo 2 blood transfusions. It is instances like these that further magnify the cracks in the U.S. healthcare system. Other similar and more recent reports have also brought cases where nearly 1 in 3 Black Californians has been treated unfairly by a healthcare provider because of their race or ethnicity. The research reports indicate that such experiences occurred particularly for 47% of Black Californians suffering from mental ailments, for 43% of those from the LGBTQIA+ communities, 40% for those with disabilities, and also for 40% of women. A significant number, 38% of Black Californians, comprising 47% women in particular, have also expressed that there have been occasions where they did not receive adequate treatment from their healthcare provider. But why is this happening? With the ugly heads of racism rearing up even when it comes to something as precious as human life, what should be the solution? And is there one in near sight? There have been suggestions of what could or should be done. For instance, given the widespread agreement on the importance of improving the patient-healthcare provider relationship, virtually all Black Californians, 98% no less, consider it extremely important to have a provider who listens to them and acts in their favor, answers their queries promptly, and discusses concerns, offering specific health goals professionally. Focus groups and surveys conducted by government agencies have shown that minorities have clear opinions and suggestions on how to improve the system to work better for the underprivileged. About 99% of respondents expressed the extreme importance of increasing ethnic representation among healthcare leaders and providers, the need for expanding community-based awareness programs, and implementing better training for providers, while also holding the system more accountable. A clear majority, about 75% of Black Californians, believe it is of extreme priority to develop more holistic approaches to healthcare, not just in the state, but across the country. With the unprecedented advent of the coronavirus pandemic, the way the world operated as we knew it changed forever. The coronavirus has since become a very real part of our everyday lives, with no respite on the horizon. How has the American healthcare system been impacted by this new age and unseen nemesis? With the outbreak crippling economies and quality of life, and severely affecting the livelihoods of billions across the world, how have Black Americans fared through wave after wave? Stay tuned to find out in the next episode on this insightful original. COVID and African Americans. There is hardly anyone on the known earth who has not been affected by the deadly whips of the new age coronavirus pandemic. However, the widespread consequences of its outbreak have been felt differently by people depending on factors, like a country's preparedness and the medical facilities available to citizens. The disease permanently changed the way we live our lives and brought about many new changes. For instance, people started to work online and from home, while homeschooling children became a norm. While the food and consumer goods brands were the first to benefit from the business opportunity in disguise, minority groups in almost every nation suffered particularly worse after effects of the waves, including in the United States. Even in the most powerful nation on the planet, the different social identities and groups seem to determine a person's vulnerability to the epidemic and the eligibility for a cure. During its initial waves, by October 10, 2020, more than 8 million people across the country and its 4 territories had tested positive for COVID-19. According to a New York Times database released at the time, about 213,876 suffering from symptoms had succumbed in the United States. However, these numbers paint an incomplete picture, as a deeper understanding of the data by segregation of social identities like class, gender, age, race, and medical history, pointed out that it was the American minorities that had been hit worse for lack of access to proper health care. The World Health Organization's eye-opening report called Closing the Gap in a Generation, Health Equity Through Action on the Social Determinants of Health cited poor and unequal living conditions as the consequences of deeper structural conditions that together fashion the way societies are organized. Poor social policies and programs, unfair economic arrangements, and bad politics. This dangerously murky combination of vital factors during the time of survival and crisis had clearly and disproportionately affected African American communities in the United States. Looking at this crisis through a human prism has helped us analyze and translate the community's social needs and problems in the interest of equal human rights, and to focus on the larger social-political structural context as the root cause of the effects of the outbreak on the African American community. There has been an increasing gap in economic inequality among the communities in the U.S., and it is also reported to be the widest among developed countries. As it has deepened further, so too has inequality in health. It is interesting to note that the U.S. ranks higher than other nations when it comes to both overall and government health spending. And yet, African Americans suffer from inadequate insurance coverage, high costs, and also geographic barriers. For example, according to a report shared by the Kaiser Family Foundation in 2018, about 11.7% of African Americans in the United States had no health insurance, compared to 7.5% of whites. With the spread of the COVID-19 virus throughout the United States, states were allotted testing kits that were distributed equally among labs across the 50 states. Given the lack of knowledge about the nature of the virus, an opportunity to control or fight the pandemic was missed, which wreaked havoc upon many Americans. The dearth of race-accurate data on the community highlighted the lack of testing among African Americans. You'll be surprised to know that, for example, in Kansas, as of June 27, 2020, according to the COVID Racial Data Tracker, only 4,854 out of 94,780 tests were Black Americans, while 50,070 were whites. Blacks also made up about a third of the state's 59 out of 208 COVID-19 deaths. And while in Illinois, the total number of confirmed cases among blacks and whites were almost even, the test numbers showed a drastically different picture. 220,968 whites were tested, compared to only 78,650 blacks. The APM, or the American Public Media, reported on the COVID-19 mortality rate by race ethnicity through 2020, and data showed an alarming death rate for all races. This clearly put the crisis under the scanner, demonstrating how minorities are hit harder and how, even among minority groups, the African American population in particular in many states bore the brunt of the pandemic's health impact. It is now in public domain that approximately 97.9 out of every 100,000 African Americans had died from COVID-19, a mortality rate that is a third higher than that for other communities, like Latinos, who accounted for 64.7 per 100,000, whites 46.6 per 100,000, and Asians 40.4 per 100,000. This rampant ill effect of the pandemic on African Americans underscored the fact that the coronavirus pandemic, far from being controlled or subdued, was instead amplifying the ground reality that the facilities and healthcare were not sufficiently reaching the community, with the community getting most infected. Experts recommended more widespread testing across the country, along with an addition in medical services in the areas. So, what does the law say? Although it is mandatory to cover insured patients who visit their doctor's office or emergency rooms, the possibility of raking up a huge bill demotivates them from undertaking COVID tests. To add to this, minority patients who do not have insurance were also seen to be less likely to be tested, even after experiencing severe symptoms. These alarming facts press the necessity of increasing the number of testing centers and contact tracing in communities and areas populated by African Americans and other minorities, along with facilitating testing beyond symptomatic individuals. Efforts were also made to ensure availing high-risk communities with more healthcare manpower and infrastructure. Programs were also implemented to meet the immediate needs of ration, food security, housing, and access to medicines, while also availing uninsured workers with financial backing. Over the past decade, the U.S. healthcare system has seen numerous legal and socio-political changes. And these notwithstanding, the Patient Protection and Affordable Care Act, passed in 2014, played a vital role in strengthening child health in the country and proved to be a lifeline to scores of American children and families during the initial outbreak of 2019. What was the impact of this act, and how did the African American communities benefit from it? Stay tuned as we bring you insightful facts and delve deeper into the act and the social transformation it brought about in the U.S. The Affordable Care Act. At the end of the previous episode, we briefly introduced the Affordable Care Act that eventually helped save millions of lives through the COVID-19 outbreak. It is important to understand its legal origins and purpose, given its radical impact on the minorities residing in the U.S., especially African Americans. 10 years ago, in 2012, a provision was made by the U.S. Supreme Court that required any citizen to maintain minimum health insurance coverage. Those who could not or did not fulfill this requirement were eligible for a shared responsibility payment or penalty collected by the IRS. This was taken as an added pressure by minorities that had already been reeling under low income and a lack of dependable jobs. The Affordable Care Act, ACA, officially termed the Patient Protection and Affordable Care Act, or in simpler terms, as Obamacare, was something of a legal landmark that brought about a significant overhaul in the U.S. healthcare system. As an after-effect of its enactment, major provisions came to be officially implemented by 2014, and by 2016, the number of uninsured citizens had, as a result, halved, with about 20 to 24 million covered additionally. The Act also officially brought improvements in delivery systems and other programs, like Medicaid, that helped to constrain healthcare costs, with an aim to improve quality. Insurers were also ordered to accept any applicant without charge based on conditions and demographic status, except age. Family is everything, and as a positive effect of the radical changes the ACA brought in the U.S. healthcare system, more than 25 million people were reported to gain from subsidized health insurance across 38 states, including Washington, D.C. Moreover, further reforms were also made in insurance, protecting the rights of people with pre-existing conditions and disabilities, while also allowing ailing young adults to remain on their parents' plans until the age of 26. This also resulted in a significant improvement in the number of children insured, dropping the uninsured rate in children to 3.6 million, which is the lowest on record. With COVID-19 wreaking havoc on the country, how did the Act help communities, especially African Americans? The COVID-19 pandemic exposed the urgency and desperate need for a health safety net for people like never before. People lost jobs and became financially suffocated by the sudden turn of events. And it was the ACA that came to the rescue of many a desperate family and patient. Along with Medicaid, the total enrollment of such programs grew exponentially, with at least half of these being children. 31 million people were directly enrolled to the Act, according to the Office of Health Policy, 2021. The Act included new patient protections that gave them greater control over the care they received, and also brought more transparency and competitiveness to the delivery systems, like hospitals, clinics, and dispensaries. The developments ensured information sharing to provide better value for the consumer's healthcare dollars. The Department of Health and Human Services, HHS, also implemented the new provisions of the law designed to empower consumers with information that was unavailable prior to the passage of the ACA. Before the ACA, because of the many marketing drives rolled by insurers, it was difficult and confusing for customers to understand what the policies covered and how cost sharing worked in order to choose the plan that worked best for their specific healthcare needs. The ACA required health plans to provide a simply written and clear summary of benefits and coverage, along with a list of definitions, designed to make it easier for the consumer to compare options and understand exactly what they are buying. The new requirements reportedly also made it easier for companies to compare health insurance options to provide for their employees. Government-run tools allowed the consumer to zero in on the appropriate health insurance policy. While coverage could be expensive, the tool helped the consumer find policies in his or her area that offered the lowest premiums and out-of-pocket costs, when searching for the most affordable option. The tool also helped anyone find coverage in the case of a pre-existing health condition. Thanks to the Affordable Care Act, health insurers are now being held accountable for increases in health insurance rates. Insurance companies are now mandated to disclose rate increases of 10% or more and justify these increases to the customer, with all the information available on government health portals online. The new provision, or rule under the ACA, known as the Medical Loss Ratio, or the MLR, secures the consumer's hard-earned health dollars. If an insurance company spends less than 80% of premiums on healthcare benefits and quality, it is mandated to provide a rebate of the portion that exceeded this limit. Insurance companies are required to now reveal how much they actually spend on healthcare and how much they spend on administration, such as salaries, bonuses, and marketing. This is information that was unavailable to the general public prior to the enactment of the ACA. Along with these consumer safeguards, the ACA also protects the consumer against the worst insurance company abuses. Under the new law, insurers are prohibited from denying coverage to children with pre-existing conditions. Before the reform, cancer patients and individuals suffering from other serious and chronic diseases could not fully avail of treatment, given an insurer's lifetime limit on their coverage. Insurance companies are now banned from placing lifetime limits. In a nutshell, the ACA puts the consumer back in the driver's seat. But how has the African American community benefited from it? There is hardly a doubt that the insurance coverage expansion ushered in by the ACA significantly increased the eligibility of ailing minorities to get the health care they needed. Research indicates that the ACA helped narrow racial and ethnic disparities in U.S. healthcare, one of the founding objectives of the law. That was also widely appreciated with public support. Data has shown how the ACA has reduced disparities in access to healthcare among Black, Hispanic, and white adults. Between 2013 and 2020, there was a dip in uninsured rates for all groups, with disparities narrowing significantly among whites, Blacks, and Hispanics. Black adults living in expansion states were shown to be now less likely to be uninsured than white adults in non-expansion states, and also experienced a larger reduction in cost-related accessibility. More positively, disparity between Blacks and whites availing equal sources of health care also decreased in Medicaid expansion states, about 1.9 percentage points, and non-expansion states to 2.3 points. Expanded eligibility with programs like Medicaid has also proven to be a vital strategy to improve racial equity in insurance coverage and access to health care. But on the flip side, about 46% of Black working-age adults living in 15 states have also not expanded Medicaid, which is a much larger share of people than the national average, along with 36% of Hispanics. The majority of Medicaid non-expansion states are in the South. To conclude, while the ACA's coverage expansions have led to nationwide improvements in coverage and access to care, the Act also reduced racial disparities since 2014. Still, nearly 8 years after the law's passage, notable gaps between people of color and whites remain across all regions and income levels. Progress has also reportedly slowed down for the African American community since 2016, with insurance coverage slightly eroding for both Black and white adults. In comparison, Hispanic adults also still experience much larger disparities, as undocumented immigrants don't qualify for coverage and cannot receive subsidies or enroll in programs like Medicaid. The policies ushered in under the ACA are aimed to make the U.S. healthcare system more equitable, but also have shown scope for additional efforts to address racial inequities in health that extend beyond access to health insurance. A recent study conducted also reiterated that a majority of the communities still do not believe that everyone in the U.S. receives equal treatment within the health system, and an overwhelming majority believe that everyone should. So why has the Medicaid expansion still not been openly and fully adopted across the country? What are its benefits, pros, and cons? Medicaid. Wherever the art of medicine is loved, there is also a love for humanity. These words by Hippocrates, the legendary Greek physician, will hold true for eternity. But when racial disparity and economic inequality seep into the most fundamental of human rights, the right to good health, how do the policies and programs like Medicaid set by the U.S. government help the citizens? Have they been fully adopted by the people? And if not, why? Simply understood, Medicaid is a program set up in a state and on a federal basis that helps limited or low-income individuals afford medical costs and resources. It also offers other benefits, such as home care, personal care services, and nursing. There have also been discussions pertaining to the advantages and disadvantages of Medicaid that vary by situation. For instance, in 2018, African Americans accounted for 34% of people who enrolled for Medicaid. The program is particularly important for the low-income community, as it notably provides more comprehensive coverage, but has also been criticized by many beneficiaries as a program that requires them to impoverish themselves to become eligible, resulting in a number of non-expansion states not fully adapting the program yet. On the brighter side, Medicaid as a healthcare program funds a number of long-term care services, while to a partial extent, private insurances fund the rest. Seniors who are fully eligible for Medicaid can receive additional benefits other programs don't cover, such as dental, vision, and hearing care. Older Americans who are partially eligible for Medicaid through the Medicare Savings Program can get help from Medicaid to pay for Medicare cost sharing, thus highlighting the importance and need of the program. There are approximately 46.8 million African Americans in the United States, accounting for a sizable chunk of the total population today. More than 5.8 million Medicare beneficiaries are African American who are significantly less well off than non-Hispanic whites. In 2020, half of all people with Medicare lived on incomes of $29,650 or less per year, and had savings of less than $73,800. However, the median income for African Americans was $23,050. African Americans were also reported to have significantly lower savings than whites, with median savings of $14,500, compared to $117,800 for whites. This shows that African Americans are more likely to have serious health problems than whites. In particular, African Americans have a higher risk than whites for certain health conditions, such as heart disease, hypertension, and diabetes. So why have some of the states not adopted the program and enjoyed its benefits? With the passing of the ACA, the eligibility for Medicaid was expanded from children, pregnant women, and those with disabilities to all adults with incomes below 138% of the federal poverty level. Under the ACA, the federal government pays 100% of the costs for new Medicaid enrollees initially, with states paying 10% after 2020. Medicaid expansion offers states with impoverished or underprivileged communities opportunities to avail insurance at relatively low costs to states where urgent care is unavoidable. Patients are treated without compensation by providers. According to a study conducted between 2015 and 2022, uninsured people in non-expansion states were estimated to consume $266 billion in uncompensated care under current Medicaid policy decisions. Were these states to expand Medicaid, the amount of uncompensated care over this period would fall to $185 billion. Yet, alarmingly, 19 states declined to accept Medicaid expansion initially, with only a few having subsequently accepted. Medicaid expansion reportedly increased African Americans' Medicaid coverage. It was observed that among non-elderly adults and children in 2013, the year before the passage of the ACA, African Americans' Medicaid coverage rate stood at 31%, while whites was only 13%. African Americans' coverage rates rose to 32% against 16% for whites in both 2014 and 2015. This analysis confirmed that African Americans gained after discrepancies narrowed across income, education, gender, age, health status, occupation, region, and other factors. It is surprising to note that yet, the coverage rates of African Americans did not surpass gains for whites, and therefore African American white disparities stood unaffected. Over the next couple of years, racial ethnic minority white disparities showed a decline statistically, and still, disparities remained unchanged for African Americans. In states that declined Medicaid expansion, many adults suffered from a coverage gap, remaining uninsured as they were ineligible for Medicaid under non-expansion rules. In addition, incomes below 100% of the federal poverty level, which is too low to qualify for subsidies for individually purchased coverage on the healthcare exchanges, was also responsible, widening this gap for 20% of adult African Americans who remained uninsured. A mindful reflection of the greater African American white disparity in states that declined expanded Medicaid shows that only 4 states accepted Medicaid expansion in 2014 upon the Act's passing. Predictions had indicated that the state's acceptance of Medicaid expansion would be based on local racial representation and whites' willingness to accept Medicaid expansion. It was also reported that while whites' willingness to accept expansion was low, the growing black population size was associated with a lesser likelihood of acceptance of expanded Medicaid. It is interesting to question why policymakers and citizens in African American high representation states were disinclined to accept expanded Medicaid. Part of the problem could be the wide disapproval of welfare, including Medicaid and other programs that are based on an individual's means. Anti-welfare sentiments also question the character and values of welfare recipients and how such people responded to incentives created by welfare. African American stereotypes over the years have become intertwined, as these very qualities are also unfortunately attributed to most African Americans. Though Medicaid is restricted to low-income people, not all Medicaid benefits are considered welfare. Medicaid is now available to the deserving poor and plays a dominant role in assisting consumers with long-term care for the elderly and disabled, and is now a leading source of financing of children's health care. Medicaid's acceptability for children is such that many financially sound adults, too, are actually seeking Medicaid funding under various specialized Medicaid expansion programs to fund additional home and community-based care for their disabled children. To add context on how impactful Medicaid has been in the U.S., half of the public is covered by Medicaid or knows someone who is, and 60% view Medicaid as equivalent to any other health insurance program. However, for non-deserving poor populations like African Americans, critics suggest that these non-elderly and non-disabled adults should be able to work for health coverage or otherwise pay for their own healthcare expenses. The statistics, however, are contrasting. 60% of non-disabled, non-elderly adults on Medicaid are already employed full-time or part-time, and 32% are incapacitated, given illness, school attendance, or caregiving. Furthermore, health insurance coverage is reportedly still not fully available for working adults. Despite these facts, there have been polarizing views and opinions on how an individual becomes eligible for health insurance coverage. This belief shapes Medicaid policy, where the states of Kentucky, Indiana, and Arkansas have adopted a work requirement, while several other states have federal applications pending to include such requirements in Medicaid programs. With such social factors deciding the eligibility of an average American individual, where do the ACA and its programs stand on tackling disparities of race, economy, and awareness? Disparities in U.S. healthcare. It is said that a hero's greatness and his weakness are both determined by the enemy. Hi, you are listening to Discrepancy in Healthcare in America. Health disparities can simply be understood as differences in the prevalence, mortality, burden of diseases, and other adverse health conditions or outcomes that exist among specific population groups in the United States. It is a sad truth that health disparities adversely affect population groups based on race, ethnicity, gender, age, socioeconomic status, geography, sexual orientation, disability, or special healthcare needs. These factors are more evident among minorities that have had a record of undergoing historical trauma, social disadvantages, or discrimination, and who systematically have experienced worse health or greater health risks than more advantaged social groups. COVID-19, more clearly than ever, has shone a light on the rampant racial and ethnic disparities in healthcare in the U.S. Before, people of color, as documented through the years, fared worse than white people in general well-being and healthcare, holding a mirror to inequities within the system and broader socioeconomic factors that drive health, that are rooted in racism and discrimination. A number of factors like racial bias, concepts of deservingness, and approval of Medicaid expansion, along with conservatism and its opposition to excessive government spending, all overlap and help us understand why there has been as much opposition to the program as there has been acceptance. Surveys conducted across large communities pointed toward 4 sources of opposition to Medicaid. 1. A preference for individual initiative and personal responsibility. 2. A belief that welfare recipients prefer welfare to work. 3. The communication gap between the wealthier and economically backward communities in fully understanding each other's struggles. And 4. There are the negative attitudes toward blacks, specifically that minorities are not hardworking and that they are lazy. Some of the health risk factors disproportionately affecting minorities, specifically the African American communities, are heart disease, stroke, and this imbalance is sadly also based on race, ethnicity, social determinants of health, and geography. Racism and discriminatory economic policies, among other factors, have contributed to these disparities by adding financial stress, thus creating distrust of the medical system. This has, in turn, hindered access to quality health care and segregated populations into unsafe and unhealthy neighborhoods. These social factors have worked to limit certain minorities' chances to be healthy. For example, by limiting their ability to afford proper medications, equipment, or preventative services, like cardiac rehabilitation, curb nicotine dependence, access to pocket-friendly exercise and equipment, improve the air quality index, or reduce pollution. Racism has been and remains to be a fundamental cause of constant health disparities in the U.S. In recent memory, unprecedented events like the COVID-19 pandemic and the police killing of George Floyd and other African Americans have further dented the trust of the community to help the system provide them with affordable health care. Taking these socioeconomic factors into consideration, the Presidential Advisory reviewed the historical context, current state, and several principles to fight disparities that emerged. Racism persists. Racism is experienced. And the onus of dismantling racism rests with all of society. It cannot be accomplished by affected individuals alone. The condition of African Americans and other minorities, the quality of housing, and neighborhood environments needed active transformation. The implementation of policies to eliminate inequities to offer equal economic opportunities to minorities is a must. Quality education and health care, and enhancing allyship among racial and ethnic groups was inalienable. Along with these reconciliations and roadmaps, a decision to accelerate investigation into the diverse effects of racism, structural, interpersonal, cultural, anti-Black, was also made by the government. With this advisory, the American Heart Association also declared its unequivocal support of anti-racist principles. Apart from heart disease, Black Americans continue to experience the highest mortality rates attributable to stroke, with almost 45% higher stroke mortality than non-Hispanic white Americans. According to studies, in the last decade, there have been well-documented disparities in the prevalence and control of health risk factors, such as obesity among youth and adults, hypertension, cholesterol, and diabetes, that have shown that disparities in such cases attributed to structural racism have been less well studied. Structural racism is a grassroots problem that limits equal opportunities and an individual's social, economic, and financial progress, which in turn results in a toxic combination of race, social bias, and health that has devastating consequences, especially in a sudden case of a pandemic like COVID-19. This is also because structural racism rests most decision-making with privileged groups and undermines minorities whose health needs to be drastically improved. In particular, Black Americans who are also subjected to the ills of anti-Black racism. For example, Black people continue to be on the receiving end of striking disparities in CVD morbidity and mortality, regardless of a higher socioeconomic status that does not protect Black people from the impact of structural racism and its health effects. Studies have reported that in comparison with college-educated white people, college-educated Black people are more likely to experience unemployment and have lower wealth at every level of income. Structural racism is thus a crippling barrier to the goals of laws like AHA that are designed to improve the health of all people, and it is only through awareness that such injustice can be eradicated, while identifying and implementing anti-racist strategies and solutions to eliminate structural racism in the United States. While COVID did its best to further dent health disparities in the country, other risks like deaths from other chronic illnesses and crimes like homicides were also leading causes for the deaths of African Americans. Stay tuned for the upcoming episode as we explore additional factors and its effect on racial and ethnic groups, including children, who are surprisingly 10 times more likely to die by gun violence than white children. Survival ratios of Black Americans. Darkness cannot drive out darkness. Only light can do that. Hate cannot drive out hate. Only love can do that. Martin Luther King Jr. Hello, you are listening to Discrepancy in Healthcare in America. Racism is the ugliest form of chronic discrimination that results in stress and oppression for the ones suffering, that adversely impact people from historically marginalized populations. And in the case of the U.S., the African American community, it is shocking that in 2023, we are still battling this multi-headed demon with no victory in plain sight. But apart from racism, there are other factors that have reportedly been the cause for more Black American deaths than other minorities and majorities in the U.S. Poverty, crime, lack of economic opportunity, and structural bias all contribute to the sufferings of the community. Let's ponder a bit more on this issue and try to understand it from a clearer perspective. Where does the problem lie? And where are the solutions? A difficult and challenging childhood and adverse adult experiences as well, attributable to community differences and violence, can result in a phenomenon called toxic stress. To add to this, the excessive stress usually leads to long-lasting damage to the body and brain, and is seen as a direct effect of socioeconomic disadvantages on deteriorating health in early adulthood among Black populations. For example, research has shown that stress-related hormones cause negative charges in the brain, causing lasting damage to memory and self-regulation. The COVID-19 pandemic, too, has highlighted disproportionate consequences among Black Americans, Hispanic Latino, and American Indian Alaska Natives. These minorities were reported to have a history of underlying medical conditions that raised the risk for severe complications, hospitalization, and death attributable to the virus. People across the world often cooperate to mutually benefit, and sometimes also exploit one another. In industrialized societies, for instance, exploitation in the form of crime has forever been related to the distribution of equal economic resources. It has been widely observed that biased societies tend to have higher crime rate, as well as lower to no social trust. An estimated 70 million to 100 million Americans, roughly 1 in 3 U.S. adults, have an incarceration, conviction, or arrest record, with African Americans ranking in the higher ratio. This is seen as a direct consequence of decades of mass incarceration and overcriminalization. Along with this, according to the Center for American Progress Analysis, nearly half of American children now have at least one parent with such a record. Failed criminal legal policies have also added to the population's stigma of a criminal record. Mass incarceration and overcriminalization is today seen as a failed experiment that has adversely affected countless lives. Moreover, it has also raised a nationwide criminal records crisis that, in turn, has become a significant factor contributing to poverty, violence inequality, and racial inequality. The killing of George Floyd and the following Black Lives Matter movement is a testimony to how deeply the discrepancies have affected people and created fear psychosis among communities. Violence inequality is another problem that exists virtually everywhere in the United States, but it is particularly dramatic in some areas. According to an analysis conducted by the Chicago Sun-Times, areas like West Garfield Park, a predominantly Black neighborhood located in the west side of Chicago, have experienced a per capita rate of shootings nearly 20 times higher than downtown. The gap in homicide rates was even more jaw-dropping. In 2021, the murder rate in the 7 most dangerous police districts rose to a 3-decade high of nearly 100 homicides per 100,000 residents, which was 30 times higher than the rate in the safest 7 districts, where the rate had fallen to fewer than 4 per 100,000. For context, poor and minority neighborhoods were reportedly ranking historically high in violent crime, while at the same time, the white areas were becoming safer. These gaps are even worse now than they were in the early 90s, long considered the worst phase of Americans' violent crime problem. Noted criminologist Aaron Chalfin shares that in 1991, the least safe communities in Chicago had rates of gun violence 13 times higher than those of the safest communities. Comparatively, in 2022, gun violence in the least safe neighborhoods was 30 times higher. Violence inequality magnifies when we understand statistics by race and ethnicity. Homicide has long been one of the main causes for African American children and young men, topping unintentional injuries, heart disease, and even suicide. According to the estimates of the Violence Policy Center, Black homicide victimization rate was 6 times higher than the overall white homicide victimization rate. The shocker is that even after such clarity and pressing need to curb and improve the conditions of the community, this inequality is hardly reported by the media, despite its obsession with nearly every other type of racial issues. What is the reason then? One answer could be that sincere ordinary neighborhood violence doesn't fit conveniently into the prevailing narrative. It's practically taboo to discuss the levels of violence that exist in parts of the United States, without also highlighting the failures of the law and order system that puts racism, capitalism, or the police under the scanner. Another problem could be residential segregation. Decades of such living strategies have widened the gap between the communities, and thus created distrust among ethnic groups. Impoverished areas also suffer from a lack of healthcare equity. Do stay tuned to the upcoming episode as we explore how residential segregation and prevailing shortages of healthcare infrastructure have added to the worries of the African Americans in the U.S. Residential segregation. Humans are strange. Years of racial and economic bias have forced the minorities into settling into separate communities across the U.S., where a lack of infrastructure, planning, and policy implementation have all contributed to an increase in health disparities. According to a study, it was hypothesized that community factors at even a zip code level in the U.S. contribute to race and ethnic disparities. Surprising, isn't it? The racial compositions of neighborhoods across the U.S. have highlighted preferences and cultures that are associated with racial identity. Minorities lack less informal access to healthcare and doctors because of the size and composition of their social networks. The lack of availability of doctors and other health professionals in their social networks is also a problem, since many don't reside in predominantly Black or Hispanic neighborhoods, particularly those that are low income. In general, the experiences of African Americans and Hispanics within healthcare are reportedly different than the experiences of whites. To add to this, information sharing and awareness, along with delivery systems and hospitals in African American communities, also vary. Studies report that higher perceived discrimination and distrust in medical providers among African Americans and Hispanics compared to whites contributed to disparities in healthcare. Residential segregation, in certain cases, has also led to the discouragement of healthcare utilization in the areas, thus lowering the demand for healthcare services in minority communities, which has been the case in a few communities across the country. The situation has also caused higher proportions of African Americans and Hispanics to be uninsured. African Americans have lower incomes and are therefore less able to pay for services out of pocket. This also impacts office-based providers differently from hospital-based providers, as reimbursement policies vary by site of care. Hospital-based providers typically receive better Medicaid reimbursement and more generous uncompensated care payments. The lack of physicians and healthcare infrastructure in minority neighborhoods is also due to substandard social amenities like public safety, transportation, garbage collection, public schools, and restaurants. Because of this, residents have to wait longer to see community providers or travel to providers outside their areas, which in turn impacts their work schedules. The lack of local providers has residents invest more in minority neighborhoods relative to persons living in predominantly white settlements. While residents of white settlements presumably have similar geographic access to providers outside their communities or near their places of work, they also have better geographic access to care at home. At the structural level, research has pointed toward the role of residential segregation as a primary factor contributing to racism and racial disparities in healthcare. Residential segregation is often considered an institutional mechanism of racism because it separates racial, ethnic groups into different settlements and determines the type of resources, i.e., employment, social, economic, and health policies available in those neighborhoods, along with amenities needed to improve life quality. Since residential segregation patterns have not changed much since the 1990s, African Americans and Hispanics are more likely to live in racially homogeneous communities. Not only this, but residential segregation is also regarded as a primary cause of disease, as social factors account for 60 to 75% of disease vulnerability. Causes such as an individual's socioeconomic status, race, ethnicity, and gender are tied to resources like money, power, prestige, and social connectedness, where those with the most access and control over resources are in a better position to avoid risks, diseases, and their effects. Social groups that live in residentially segregated areas often lack health resources like doctors, access to public information, and innovative technologies that are needed to fight disease. Minorities that reside in homogeneous settlements have a double disadvantage because society sometimes deprives them of opportunities. They reside in neighborhoods that do not offer similar quality resources and public services available in white communities. For these reasons, residential segregation manifolds the health needs of persons living in minority communities, thus increasing their demand for healthcare services. Among the minorities, African Americans living in predominantly white zip codes had less access to health professional services compared to whites in white zip codes. The disparity was greater for African Americans in predominantly African American, predominantly Hispanic, and integrated zip codes. For Hispanics, it was found that those living in white zip codes were about 35% less likely to use other health professionals than whites living in white zip codes. Further findings have indicated that disparities in healthcare are related to both individuals and the community's racial and ethnic identity. How does one solve the crisis? Efforts to improve access to healthcare services and eliminate healthcare disparities for African Americans have been underway, with added focus on factors on an individual level, and, in addition, on physician services. It was also found that public policies should prioritize public awareness and promote allyship between communities, as they are key factors that contribute to these disparities in non-physician services. Together, the findings highlighted the importance of community health and population-based approaches to improve minority health under the Racial and Ethnic Approaches to Community Health (REACH) program, in a bid to serve more than 40 communities across the United States and address priority health problems like cardiovascular disease, diabetes, breast and cervical cancer screening and prevention, asthma, immunizations, and infant mortality. REACH has 4 targeted populations: African Americans, Asians, Hispanics, and American Indians, Alaskan Natives, and works toward planning, developing, and implementing effective interventions that improve minority health in their communities. With such efforts, it wouldn't be wrong to assume that we have put one foot in the right direction towards eradicating disparity in healthcare by solving grassroots problems that hinder the common man's health and progress. What are some of the other solutions that could be implemented to improve the conditions of healthcare for African Americans and other minorities in the U.S.? The Silver Lining. Hello, you're listening to Discrepancy in Healthcare in America. In this fascinating series, we have explored the many socioeconomic factors that hinder healthcare equity among minorities, most notably African Americans, seeing their devastating impact, especially in times of crisis, on the scale of something like COVID-19, and also try to understand the efforts that are constantly being made to improve the conditions of residential areas dominated by minorities, to better serve them with medical facilities and social amenities. However, it is not enough to simply identify the problem, but also to offer solutions to solve it, which is paramount. Given the nature of how health disparities spread across communities in the U.S., it can be easily understood that it is also preventable by managing circumstances that affect an individual's health status, like income, ethnicity, education, age, and gender. These are key social factors that can result in the lack of access to proper healthcare resources, including insurance. Healthcare administrators help advance health equity by looking at data. It can help them understand health disparities like mortality, life expectancy, burden of disease, mental health, uninsured and underinsured, and lack of access to care, and who it affects the most. Data has shown that African Americans were more prone to mortality compared with older white adults. The good sign is that this gap has narrowed for individuals in urban areas in the last 60 years. Contrastingly, however, the gap widened between Black and white men living in rural areas during the same period. The National Cancer Institute highlighted disparities in mortality based on educational background. Less educated individuals from any race are more likely to die from colorectal cancer before 65. Did you know that the 20th century began with a life expectancy difference of 14 years between Black and white Americans? The gap decreased to 4 years recently, thanks to improved access to healthcare and economic status. Equal job opportunities and unbiased employment across sectors had proven to help solve the crisis a great deal in certain cases, until the COVID-19 pandemic brought progress to a halt. The average life expectancy is down by a year for everyone, according to studies. But active efforts and programs are being implemented to regain lost pace. Causes of disparities in diseases such as asthma and diabetes include racial or ethnic bias. For example, Black and Hispanic populations are more likely to suffer from asthma than other U.S. residents. It is rather interesting to note that airborne malcontents do affect every community equally, but the difference is in the accessibility to healthcare. That marks a huge difference. Puerto Ricans, for instance, are reported to have the highest rate of asthma prevalence compared to any other racial or ethnic group in the U.S. Genetics may play a role in the biological construct of these populations, but evidence points to asthma disparities being majorly rooted in race-based bias. Another growing concern is mental health. About 1 in 5 U.S. adults, 51.5 million people, lived with a mental illness in 2019, according to the National Institute of Mental Health, NIMH. However, some groups are affected more than others. For example, about 70% of young people in the juvenile justice system are reportedly from the African American community and have been diagnosed with a mental illness. The causes are exposure to childhood trauma, crime, violence, and social and domestic abuse. The solution is an economic parity, the fairness of medical equity, and the distribution of infrastructure among minority communities. Equal job opportunities and pay parity ensures the affordability of expensive healthcare, thus also ironing out discrepancies. It is only because of economic backwardness that individuals from racial and ethnic groups who come from low-income backgrounds often face barriers to accessing healthcare in the U.S. For example, the low-income regions have fewer mental health providers and fewer physicians than the rest of the country. In conclusion, what can be the potential solutions for health disparities? Healthcare leaders and medical professionals can promote health equity by actively prioritizing access to healthcare. Additionally, facilities can implement community outreach efforts and chronic disease management programs to improve awareness in affected populations. Let's ponder over other possible solutions. Education. Education can help address health equity. It can also help populations most harmed by health disparities. For example, healthcare organizations can help reduce ethnic health disparities by increasing ethnic representation and competency, by offering training programs in affected regions. Awareness. Healthcare organizations can play a pivotal role spreading health literacy of affected groups by expanding educational programming, eradicating social, racial, and economic inequities by using health disparity data and evidence-based clinical knowledge can help solve the crisis a great deal. Resources. Since racial and ethnic groups are less likely to have proper access to health resources and are typically underrepresented in the healthcare workforce, strengthening healthcare resources can help providers better serve people in these at-risk areas. Collaboration. Healthcare facilities can collaborate with agencies, organizations, coalitions, boards, and councils working on initiatives to address the root causes of health disparities. For example, the American Medical Association, AMA, works to diversify the physician workforce to reflect communities' racial and ethnic backgrounds. The AMA also funds public health literacy programs. Tracking. Monitoring and documenting a program's effectiveness and health impact can help healthcare organizations to determine what's working or not to improve health outcomes for all communities. The first and foremost discrepancy in healthcare in the U.S. is racial and ethnic bias. While a majority of the population and organizations are actively working towards eradicating this age-old obstacle to human collaboration, development, and progress, there is still a pressing need for many to nip it in the bud. Coming generations need to be educated and informed, groomed and polished into a raceless single community that lives together and fights together, loves and works together towards a collective single goal, that of prospering together without bias and disparity, not just in healthcare, but in every aspect of life. The day we achieve this vision, we will fulfill the true American dream. This brings us to the end of this series.